Yeah, so I think on the side of the family caregivers, to remember to take that initiative and say, I'm the caregiver, here are my other family members, and here's how we want to be involved in the care. But, it's a delicate balance too, because you want to work within your family and the norms of how you support that partner's autonomy. But everyone's different, and they'll know how they like to talk to the doctors together. But for clinicians to, think about how one is communicating with everybody in the room too, because I think naturally clinicians are doing a great job and, asking a lot of these questions just because it's making sure that everybody is, they're doing well, and that's their job. But maybe once in a while, it's good to be self-aware and say, who am I looking at? Why am I giving these instructions? Am I including both people? It's definitely a challenging task, but maybe, think about this as a whole area that you're talking about. So,
Well, extending that, the issue of like patient privacy and autonomy is just a huge one because clinicians need to make sure their focus is appropriately on the patient. And, they need to make sure that, patients can choose who they want to share information with in terms of their family. And it can be really hard for the doctor to know when to say, I just need a moment to speak just with with my patient right now. And
mhm.
like, we'll just ask you to sit in the waiting room and we'll invite you back in later. And it's just hard, as you say, the delicate balance of hearing the caregiver's concern, especially when the person has dementia and there's a fundamental tension between the patient's autonomy and the caregiver's concern for the patient's safety, and making sure that those are two adequately balanced. You don't want somebody to be at home who's unsafe, so you want to make sure that you're listening to what the caregiver has to say, whether it's about driving or food preparation or wandering. This is in, that dementia context, but you also want to make sure that if the person does have capacity, if your patient has capacity to, hear that full story. And abuse is another whole other can of worms, but it's something also to think about. And then the final thing that I would say is the challenge around reimbursement. Clinicians just aren't generally compensated for the time that they spend with caregivers. There are some billing codes in place, again, also mostly in the context of dementia, where there are care management or transitional care codes, but they're not widely implemented or used. And again, it's sort of a flaw of our medical system that it's not set up well. So you can be the most amazing clinician and have the best intentions to have these triadic three-way conversations, but so many challenges. The cards are a little bit stacked against you. I don't mean to sound pessimistic. We will talk about other happy things.
Yeah, well, and this is why you're doing the work that you're doing, because hopefully we can kind of facilitate ways that just make it more structured and supportive for clinicians. Because I think about, even in the case of dementia, where there's this struggle between autonomy and safety, and there's different perceptions of the care partner and the person living with dementia in research. We separate them, and we have them talk about their own concerns and their thoughts, so they're able to kind of speak more freely about what their unmet needs are, or kind of what they're concerned about for the relationship. And then we also bring them together to, understand as a couple or a dyad or partners or a mom or a dad. But I'm thinking about, the clinical space where there's not enough time to do that. I'm wondering if there's ways to get over those complex situations where they're talking about me behind my back, like in the hallway. I know you were talking to me about that. So just kind of how could we help clinicians head that off before it happens?
So that's a really, really important question, because I think, well, first of all, our medical schools need to focus on provider education around like these like communication tools and toolkits and scripts that can be provided in advance of, or CME credits, for example, where you can learn more about the delicate balance and the communication style and interacting not just with different families, but also with different cultures, because our United States is just getting more and more heterogeneous and more diverse. And something, for example, in certain cultures that they want to bring their entire family in into the medical visit, and it's really important to have that family-centered approach. Whereas others, it's all about patient autonomy, and I'm the one who wants to be able to speak. So I think what it comes down to is really understanding first and foremost from the patient, maybe having a separate consultation with the patient alone and saying, what are your preferences and values for the way that I interact with and communicate with your family? I understand, can you let me know, let's walk through a day and tell me about your health conditions and how they're managed. Do you have anybody who helps you at home? What are they doing to help you? And then making sure that you understand from them around what their preferences are for family involvement. And this may sort of be in contrast with what the caregiver wants or needs, but your responsibility as the clinician is always to your patient. And I'm sure that, in most circumstances, the caregiver wants the best. You all do. As the clinician, the patient, the caregivers, everybody wants the very best for the patient. And so, engaging with that person once the patient has identified who these people are in their social network, then you can start speaking with them. That's why, the point of identification, just knowing who these people are in the first place and what their roles are, is essential to then coordinating the care and understanding that delicate balance during the visit.
Yeah, I mean, there's so much on, relationships and following through with health behaviors when you have chronic conditions, the example of someone who has diabetes, but their grown children express their love by bringing donuts on Sunday mornings. And it's these relationship interactions that could get in the way of what the clinician is trying to tell them. So not that you have to know, like everything about the people's ways of interacting with their family, but it would be helpful to know the certain kinds of relationship dynamics or barriers that are getting in the way of the certain actions that clinicians are trying to tell their patients to take. So, like whether it's the medications being affected by one child saying, I don't want them to take it, and the other one saying, I do, it really would be helpful to know these kind of dynamics.
Yeah. So, and a lot of it, as you mentioned, either is the family trying to show their love through donuts, or there might be cultural things that, we all gather, sort of in the opposite, where, I know so much about your work is sort of the dyadic, where one spouse is going out to exercise. Oh, come with me, come for this walk with me, or let's do yoga together. And so it can really go in either ways. And some of them, might be more positive. And that's also important for the clinician to know about, who's the person who's getting you out for your run or for your walk and helping to lower your blood pressure, cooking the special meals for your diet, or managing the medications, or translation services and those types of things. Like, is there somebody at home who doesn't speak English that I need to be aware of so that we make sure to communicate more effectively?
Yeah, so now I kind of want to turn to the well-being of the care partners or the family members, because we've been talking a lot about, how families can kind of facilitate care of the patient. But what's the responsibility of the clinician for paying attention to the well-being of the care partner, and how should they go about doing that?
So it's really interesting because in a survey of primary care physicians that I did in this national sample, virtually everybody said, all of the family medicine doctors, the general internists, and the geriatricians, everybody said it's my responsibility to identify caregivers' needs. Everybody felt really like responsible for it. They felt like it would improve the care of their patients. And so there is even just a general consensus that we are responsible for the caregiver and understanding their emotional needs. And part of this does kind of link to our earlier conversation, which is the caregiver who doesn't feel validated or who is struggling with emotional health needs, whether it's depression or anxiety or stress or burdens, or if they're just feeling overwhelmed by what they're trying to accomplish, those people are not going to be able to support the patient. So it does kind of come full circle, which is why I think that clinicians feel responsible for identifying and addressing caregivers' needs and concerns and risks, because it does have an effect on their patients. On the other side, too, the caregiver might be their patient, or it's a patient of somebody else. And these are often people who are neglecting their own health because they're so focused on caregiving for their loved one that they may not have time to go to the doctor themselves, which is why I think it's so important to attend to those emotional concerns and needs during the visit. Even just those questions can help. Just a couple of questions about how the caregiver is feeling during the visit can provide sort of a sense of relief and validation and, oh, somebody's hearing me. And that almost can be enough sometimes to make you feel good and like, okay, I can do this because I feel like somebody's listening to me. The doctor cares. They know how stressful this is and how hard I'm working, and I might be juggling other responsibilities. So kind of along those lines, and you mentioned sort of confidence and self-efficacy of the caregiver to raise concerns with the doctor before. And I think it's so important. And to this end, part of my work has been developing and validating and testing a checklist that we give to caregivers in advance of the patient's visit. And part of the reason for doing this is some caregivers and many people who are watching this podcast may think, yes, I go in with a checklist. I have all of my questions written down. I know I'm in charge and I have everything written down and know. But the people who might be watching this podcast may not be representative of the whole population who may have language barriers or cultural barriers. We want to be able to support those groups of people who might have that white coat syndrome. When you see a doctor, I even get this when I go into the doctor, I forget everything that I've thought about. I have a zillion questions in my head. And then you see this person and you start to break down and you get really nervous. So we've developed a checklist where they can just check off whatever they think to be able to prioritize their main issues. So it's just 8 items, about their mental health, their emotional health, managing the patient's medications, their health conditions, anything that they think that they might want to talk about or might need help with during the visit. This is sort of to promote that self-efficacy that you're important. And the doctor will respond to you because not everybody has that in themselves to be able to advocate and ask the really important questions. So even just the simple checklist, and this is not fancy, it's paper and pencil, just to show that, look, we're listening to you. And the important thing about this, and this has only been a pilot study so far with about 40 dyads, but we've shown that having this checklist doesn't add anything to the visit time. Visits are actually even shorter when the caregivers are given the checklist, but it does help them to actively prepare for the visit, which I think maybe streamlines the communication. It helps the doctor to know what's coming in advance. It helps people kind of set their agendas so that there are no surprises, and you can target the biggest unmet needs. And a question on it has to do with emotional concerns. So that might be some way that the doctor can say, look, I understand that you're really, let's talk about this. Let's talk about the concerns that you have in a non-judgmental way.
Yeah, so this is so great. I feel like we need one of these checklists for like all of our visits, like with our kids and everything too. And like me and my husband have the same primary care person, and so I wonder how often that happens, and if it's perceived as helpful for older adults, to have the same primary care person. So a lot of them probably go to the same doctor. And if you think about that with family medicine, that has been a tradition in the past, there's so many benefits to that because they know about the other person's care and they're not isolated from each other in their care.
That is such an actually, when I was conceiving of this project, I thought about focusing just on spouses for this very reason, who may be seen in the same clinic. And part of that kind of gets around the issues of reimbursement and HIPAA, sort of the privacy stuff, because you're seeing the same person. So there's some sort of supportive atmosphere, but I think it's an excellent question to start thinking about, especially for spouses who are seeing the same like PCP. We can sort of support family-centered care in that way, and especially in a geriatrics practice where all of those issues should be attended to. It seems like a very logical fit and next step.
Yeah, and with trying to do research that's not getting in the way of the healthcare practices that are a little bit more pragmatic, we're trying to look at outcomes in the electronic health records, and I wonder if that's a way to monitor any kind of outcomes on the family care partner that's a spouse specifically that sees the same primary care person in a way that we don't have to go in and have people fill out consent forms and answer questions. So yeah, we have something new to do together in the future, Catherine. So I want to ask a final question. What are kind of like your recommendations or take-home messages in this work that you're doing with primary care and trying to make things more family-centered? I know it's a big question, but maybe a few simple points that you could summarize in your work that you've been doing so far.
You mentioned it briefly in that past comment about, I think there are a lot of lessons that we can learn from pediatrics and sort of vice versa. So with young kids, when I was pregnant all the way through, the very early years of life, they hand me a screener about I get a very short depression screener, interpersonal violence screener, about the social determinants of health, like our housing security or food security. And I think those lessons could really be very easily transposed to the geriatrics setting where, you're just asking a couple of questions. And, as I mentioned before, this can be streamlined. They can be very quick questions around how are you doing? How are you feeling? What do you need to care for yourself and for the patient? I also think, so for clinicians, those are just kind of simple things that can be done. I also think that our health system just generally could benefit from some overhauls in terms of integrating the behavioral health and physical health issues to help people get some of the social resources that they need and help us create more holistic, family-centered care.
Yeah, there's so much time spent in those waiting rooms when you're a care partner that maybe some of the time they could just pass it with a little iPad or a piece of paper, if people don't like technology and, just thinking about doing that check for yourself. So yeah, thank you so much for all the work that you're doing and hopefully we can collaborate on some of this stuff we talked about today. It was just so wonderful to have you back and talk. And thank you so much.
Oh, it was my pleasure, Joan. Any opportunity to get to talk with you is just the best.
All right. Have a wonderful day.